Okay. Hi everyone. Are we ready to start? That's great. Okay, so welcome to the session on applied neurodiversity. My name is Natalia. I'm a neuroscientist at the University of Cambridge, and I'll be your chair today. And today we have Holly Sutherland and Dr. Max Davie presenting on applied neurodiversity. Our talks will happen back to back, and then at the end we'll have a Q&A session. And I'd advise you to submit your questions through the app because I can access them directly on my iPad and ask our speakers after the two talks. But if you happen to not have the app installed or it doesn't work for you, there is a mic here that you can come up to, and I'll call on you when the time comes. Okay, so first off, we have Dr. Max Davie, who works in Lambeth as the lead for the Over Fives Developmental Clinic. He's also the founder and trustee of the charity ADHD UK. And he's going to outline an approach to supporting neurodivergent children, incorporating a stepwise clinical approach, which is supported by local networks and relationships. So, yeah, take it away.
Thank you. Hello, I'm going to take it away. So you've got a little bit of the intro of who I am. It's worth briefly mentioning, because I'm sure you've all come to see Holly. I work for the Evelina, but I'm not necessarily somebody who works, and this may be irrelevant to most of you, but for some of you, it may be relevant. I'm not somebody who works in a large tertiary centre and has lots of money to spend. I work on my own. I see my patients on my own almost always. So the stuff that I do, I'm not saying we should be doing with a huge amount of resources. I'm working, I would regard as quite a resource-constrained environment. I am also, my friend Henry and I founded ADHD UK a couple of years ago. Brilliant time to found, as you know, just before the pandemic, a new charity. It was a fantastic time to be a fledgling charity. As you can imagine, nobody was doing any sponsored runs. I also have had a podcast, and I'm now podcasting for ADHD UK on ADHD science. So I have been accosting people around the conference, asking them to come on. And I have my eye on an interview with you. But we have previously done Extraordinary Brains, which is neurodiverse stories, people's life stories. So me and my daughter, Tess, interview people. We'll put that on hold for now while we do some science. We'll probably come back to it. And I'm also a member of the tribe. I was diagnosed with ADHD in 2019. And I've been sort of thinking a bit about that since. So the thing is, what I was wanting to do is try and give a kind of pointer of how the wonderful ideas and kind of stimulating discussions that we've been having over the past day. I mean, I'm very delighted to have had a whole day yesterday when I didn't have to do any talking, except over coffee. How do you apply them in an NHS clinic, sort of at the front line, as it were? You need to start really from what the children and young people themselves say they want, the people and your patients. And actually, if you look in the literature for children and young people, there's very little, unless somebody has got some data that I can't find. There's really very little. But from adults, there's a lot of feedback about the system. And I think those are very, very familiar. I'm not going to read them out, but they're very probably familiar to all of us, how people actually experience the system around the support of neurodiverse conditions. So the question is, I'm not a researcher, I'm not an academic, and so I don't have a list of priorities which are sort of evidence-based. But my N number is quite high, so sort of several thousand patients seen since I started the clinic and started running the clinic 14 years ago. So it's from my experience and also from my engagement. I want to sort of call out the local engagement, my local engagement partners, such as the other thing I didn't mention is that I'm also trustee of a local ADHD charity, ARCS, in Lambeth. And I think they'll come back into the story quite a lot because it's only by local engagement that we've been able to achieve anything really in Lambeth. So this is what I think I prioritize when I see somebody who may or does have a neurodiverse condition. So they need obviously assessment, understanding brain health, support at home, support at school, and access to treatment/therapy. Now I've put requires diagnosis for two reasons. One is obviously there is a gatekeeping function due to the regulatory framework that we exist in, but also to emphasize that the rest of it doesn't require a diagnosis. That's really, really important to me from a practical level because of how long people wait for diagnosis, but also conceptually, I think it's very important that we don't gatekeep support using diagnosis. That seems to me vital. So I'm going to go through each of those 6 things and sort of express them a little bit, what I think people have a right to, what is required for them to access that right, and very importantly, what are the barriers. This is not 20 minutes on how brilliant things are in Lambeth, because that would be boring if you don't live in Lambeth or surrounding boroughs, which given we're in Edinburgh is unlikely. People need to have access to a needs-based holistic assessment. And diagnosis may or may not emerge from that, but diagnosis is not the be-all and end-all or the purpose of assessment. The assessment is there to assess the child's needs. So you need clear referral pathways, you need a single organisation covering an age group. What you don't need, but you often get, is one organisation for 9-year-olds covering ADHD and a completely different organisation covering autism within the same borough, which we have in adolescence, which is totally unacceptable, even in Lambeth. And you should minimise duplication, which is a related point, but if we are in a cash-strapped NHS/public services in the UK, why on earth are we duplicating? It doesn't make any sense. And of course, we need adequate resources given, with an optimally efficient system, if we have adequate resources, then we'd be okay. Commissioning is a complete mess in the UK, and we can talk about it. I know that commissioning is different in Scotland. It's probably a little bit better in Scotland and Wales than England. England is an absolute car crash for commissioning. There's a postcode lottery. So even between me, so Lambeth is run by Evelina Children's Community. Southwark is also run by Evelina Children's Community, but the system for ADHD is different across the 2 boroughs for reasons that I can tell you over coffee, but I can't stream publicly on the internet. And then there are, related to that, professional barriers and defensiveness. So it isn't just there's not enough money. I don't want to stand up here and say we just need more money, it'll be fine. There are professional barriers, there's professional pride, there is defensiveness, there's silos people retreat into. That definitely happens, and that definitely needs to be addressed. But there is also no money. I mean literally no money. Everyone who comes and gets a neurodevelopmental diagnosis or has needs identified need to an understanding. And the understanding that the thing I trot out, and it may sound a little bit like a Facebook meme, which dates me, I should be saying Instagram really, shouldn't I, is ADHD or any condition like that makes some things more difficult but nothing impossible. And that encapsulates a lot of how I approach the specific problem solving in neurodevelopmental conditions. In order to have that universally understood, you need to have universal professional CPD on neurodiversity. Absolute basic minimum. Psychoeducation, which is often trotted out after diagnosis, needs to be a conversation. Conversation between professionals and families and young people. And I emphasize that point for reasons. And there needs to be an attitude towards the person of constructive challenge. So not on the one hand, oh, you've got this thing, you don't have to do anything. Or on the other hand, oh, you've got this thing, I don't care, just, you still have to tuck your shirt in, which is maybe a bit of maybe a little bit of trauma from my school days coming back in. But unfortunately, CPD is very patchy. There's no central mandate for CPD in this area at all, and so it very much depends on a local clinician getting very interested in these things and, for instance, going around to all the schools and giving a talk, just to take a random example. Psychoeducation as an info dump. I think very often you tick the box of psychoeducation by putting out a video or sending out a leaflet. That is not, for me, psychoeducation, because it's not a conversation. What if someone's got questions? What if they don't really understand? Or if they think they understand what you're saying, but they get it at the wrong end of the stick? It doesn't make any sense. It's got to be a two-way conversation for it to be meaningful. And then, of course, there's judgmental people, as there are everywhere in a neurodivergent person's life. The young person's able to enjoy good brain health. It was very nice that we come after Pierre, I can't pronounce his surname, the professor's talk, and the importance of exercise. So I would add sleep into that, absolutely vital to get good sleep if you are neurodivergent in order to function. Exercise is important, so get your lactate in, and positive mental health. Those are the things that I focus on when I think about, well, okay, you've got this condition, or you've got these traits, how, irrespective of that, we need to make sure your brain health is good. Diet is missing from this. I'm skeptical about some of the nutritional claims being made about neurodiverse conditions. What is the barrier to good sleep? It is mainly in Lambeth housing. If I could change one thing, if we could do one thing for our neurodiverse populations in clinic, is just to improve their housing. It makes much more difference than anything we could do medically. The built environment is very important for access to exercise. And I mean that that includes not just access to parks, but also safe roads. It also includes just simply feeling like you have a lift that works in your block and safe outside space that you feel you can access. These basic stuff. And where you start, I could do a whole different talk, and I'm halfway through my time, so I'm not going to go into, but it's individualized why somebody might not have positive mental health, and we just need to have a talk about that. It's important that families are supported at home to help the young person to function. I really emphasize peer support, because I think peer support, you will always have someone out there in the borough or in the area you are who's been through where you've been, who can absolutely sympathize with where you are now. So it's vital that we have peer support. There is also a place for professional support, and I would put a plug in if there is oppositional or conduct features of the neurodevelopmental presentation, that a more formal parenting intervention is evidence-based, cost-effective, and should be available. The barriers, it was very hard to maintain peer support. We've got reasonable peer support because we've got some wonderful parents locally, but they do need help. They can't just do it on their own. They need input from people whose job it is to do this stuff. But unfortunately, there isn't money to do this. The gutting of social support since 2010 has made professional support much more difficult for families to access. And not to get too political, but 2010 is obviously a key milestone. And then there's also stigma to being engaged in a parenting intervention. It is still something that people feel stigmatized being invited to do so. And so a lot of the work I do around this is basically trying to convince families that we are not, the fact that they might need this is not a reflection on their competence or commitment to being a parent. Schools are enabled. I do have a really good relationship with schools, but sometimes they need a bit of a prod. Sometimes you need to be carrot and stick with schools. They need to be encouraged to support neurodiverse pupils. So you need effective CPD in schools, including culture change sometimes. So moving from a kind of zero tolerance. You need, related to that, there are two sets of guidance for schools. One is the behaviour guidance from the government, and this is probably the same in Scotland, I think it is. And then there's this SEND behaviour, but they're not really integrated at all. So if somebody is behaving in a particular way, which one do you apply? If they have SEND, particularly if they're not clear, if it's not an SEND school, you obviously need adequate resources in schools for support, and you need good communication between schools and between schools, families, schools and other agencies. The barriers to this, of course, is that provision of CPD is entirely inconsistent because of this lack of a central mandate. There are silos within government, which again, date from 2010, which prevent there to being integration of policy. There is austerity, which has meant that we don't have adequate resources in the schools, and that's getting worse, not better. And there's a lack of local coordination, which is not just down to money, but is partly because there isn't resource dedicated to coordinating local schools together in lots of areas. So because there isn't that person bringing it all together, a local person, a local coordinator for schools or whatever post you might need, there isn't that provision. We've tried to do something in Lambeth. We're doing a project with the ARCS, local ARCS charity, looking at transition from primary to secondary, and just basically building a system so that schools can easily and consistently transfer children with SEND from primary to secondary. But it's astonishing, it took us doing it, and everyone's like, why haven't we done this before? I'm like, well, I don't know, I'm just a guy. When working with this group of parents, and you've been Senkos for like 20 years, why, I don't know, you tell me why I haven't done this before. And then there's access to therapies and treatment. And I've put this last, partly because I do it last. Very often when I make a diagnosis for a child, I say, we'll get to all this other stuff. We'll do items 1 to 5, and then come back and we'll talk about treatment. Obviously, mental health assessment and treatment should be available. You need engagement as necessary with AHPs, OTs, speech and language therapy, and physio. And you may need medication, or at least you need access to discussion of medication. There is a lot of barriers. I still occasionally come across a mental health service that essentially excludes people who have autism because they will either, I think a few years ago you had mental health services who would explicitly say we don't take children or young people with autism. Now it would be more whenever a referral comes in, they'd say, oh, this is a symptom of their autism, we don't need to see them. So it's an informal rather than a formal block, because I think they've realized that it's probably illegal to say you won't see somebody because they're autistic, but it still happens, and it's very frustrating. There obviously is resource implications. One of the things that's very sad is as the money has shrunk compared to demand, people have shrunk down their involvement, and it's gone from a more meaningful engagement to you get time-limited, very focused interventions from these therapists, which is fine, and it looks good on paper for the service, but then you get to the end of it, and often the families are like, well, we'd had some stuff, but we're not really sure what happens next, and they sort of mumbled something about us calling them if we need them, but we're not really sure quite what's happening. So it just feels to me like, because as services have become more and more tight with the way that they use their resources, families are just feel a bit more like it. They're in on a conveyor belt, which they may feel like with us as well, which is just really unfortunate. And then, of course, if you leaving aside the debates, the very valid debates about medication and its appropriateness, there are waiting lists for these conditions and waiting lists to see me. If you want to, I try to get people in as soon as possible when they think they want to talk about this, but strictly speaking, we've got a 6-month waiting list if you wanted to go through the kind of proper channels, but I just try and get people, try and squeeze people in if they come back to me and said, yeah, you talked about this thing, maybe we want to go for it. But there are also restrictions, so it is difficult. A lot of these medications need to be done by a particular person. A lot of them are controlled drugs, and so it's very difficult and a faff to get them. So some of these restrictions are justified, and I wouldn't say we want to get rid of them all, but they are there. They are a barrier to people getting therapy that they might feel that they would be helpful to them. So this is effectively my last slide. So I've got 2 minutes left, which is great. So I put the question mark against top. They're tips. If you are somebody who's engaged in this work area, these are the things that I have found helpful. I want to return to the point that you must empower and involve local parents because they are not only going to be a really important source of peer support to other parents, but they're also really very much more difficult. If you take some local parents, not take local parents, because that sounds like you're bringing them along. If you ally with local parents groups and you go together to meetings with commissioners, to meetings with your local mental health service, it's very much more difficult for them to say, oh, well, this isn't really a problem. It's they're just a very, very, very helpful ally to have when you're trying to persuade people to prioritize this area. In fact, I think if you go along without local parents, you're really missing a trick. Push for integrated commissioning. I have not succeeded. I still, every day of my working life, despair at the fact that we have this hopelessly stupid system for adolescents where they have to come to us for autism and go to a completely different NHS trust for ADHD. It makes absolutely no sense at all, and that drives me completely bonkers. And that's after me being there for 13, 14 years, saying repeatedly, this is ridiculous, we should stop doing this, but we're still doing it. And so I'm not saying we need to do it. I'm not saying you always will succeed, and I certainly haven't. But however, what we have to an extent succeeded in these local strategic partnerships. Because they are mandated by NICE guidance for autism and ADHD, they tend to be condition specific, but there's no reason why they can't also work together, which we have to quite a good extent in Lambeth. There's an autism strategy group and an ADHD strategy group, and a kind of regular meetings between those two. So that's quite good and quite helpful. At least you can get together with people who also get it and kind of recharge yourself and kind of get a bit more purpose. I find that's really the main reason I really kind of cling to this partnership is it's other people who also agree with me. I know I'm out of time. And cultivate schools. So I might be critical of schools at times, but they are absolutely vital to our work. Right, that was me. There's some Twitter handles that I keep an eye on, and I will take questions afterwards. Thank you very much.
Thank you very much, Max. That was a very interesting talk. I feel like you highlighted a lot of the issues and also solutions for providing neurodiversity-oriented care, so thanks very much. Next up, we have Holly Sutherland. Holly, if you'd like to proceed to the podium. Holly is an autistic autism researcher and doctoral candidate at the University of Edinburgh. And today she's talking about creating environments that are accessible to and supportive of neurodivergent people. But she also asks, what does support mean in the context of neurodiversity? And what are we supporting people towards, and for whose benefit? So, Holly, when you feel comfortable, take it away.
Thank you very much for that introduction and for the great talk by Max. Hi, I'm Holly Sutherland, and I am, in approximate order of relevance to this talk, an autism researcher, autistic, and a PhD student. And I'm going to talk today about support and interventions for neurodivergent people, specifically how neurodiversity as a concept can inform when, how, and why we intervene. So I'm not going to go on defining neurodiversity because hopefully by day 2 of ITAKOM you've at least got a general idea of what it means. Instead, I'm going to highlight that neurodiversity as a framework claims that differences in neurotype are not inherently deficient, that there is not a single correct way for a brain to work. This is a powerfully liberatory framework for anyone who thinks, learns, or perceives the world in a way that differs from the norm. But it does raise some pretty key questions about support and intervention with regards to neurodivergent people. Mainly, what are we doing and why are we doing it? If we acknowledge we shouldn't be aiming to make people more normal, that there's nothing inherently wrong with differing from the norm, then what are we supporting? Why are we intervening? Should we be intervening? To answer this, or not answer this, because this should be an ongoing dialogue between neurodivergent people, researchers, parents, carers, educators, health workers, etc. going forward, but to start thinking about how to answer it, there's three key questions I think we need to consider. So 1, why is neurodiversity a useful concept regarding support and intervention? 2, what are some key principles of neurodiversity affirming support? And 3, when is providing support and intervention even appropriate if we're trying to be neurodiversity affirming? So first, why is neurodiversity a useful concept when we're talking about support and interventions? To answer this, we have to answer why, if neurodivergence is not inherently a problem, neurodivergent people need support and interventions. And to do that, I am going to ask you to indulge me for a few moments and imagine a jug. Here's a picture of a jug for reference. I don't want to overtax anybody's imagination at like 9 o'clock on probably 10 o'clock on a Tuesday morning. And this jug is excitingly you, or rather it's your capacity to get tasks done, to self-regulate, to concentrate, to learn, whatever. Here's your jug. And now I'm going to ask you to sit a really easy maths test, except before we get started, I'm going to put a rule in place. No smiling. If you smile during the test, you lose points. There goes a chunk of your jug, filled up by the fact that part of your capacity now is focused on remembering not to smile. Also, you really need to pee, but I'm not going to let you use the toilet before you take the test. So that's another chunk of the jug gone, trying to ignore how uncomfy you are. Also, I'll be playing music from my new favourite garage punk band during the whole test, so more jug gone. I've also printed the test in really small text, so you're going to have to squint to read it, more jug. And at this point, let's collectively imagine that you turn to me and politely explain to me that all of this is making you really stressed about what should be a very simple maths test, to which I suggest that you try some breathing exercises to make you feel less anxious. And maybe this does help with the stress and anxiety. I'm not here to knock breathing exercises, but it is another thing to remember to do. It's another chunk of your jug. And now it's time to sit that nice, easy maths test. Now that I've given you an arbitrary rule to follow, 2 separate sensory distractions, an inappropriate test format, and a helpful intervention to deal with all those access barriers I have just put in place. Except you have no more capacity. That nice, easy maths test is suddenly impossible. And this is a silly little hypothetical scenario, but it's also essentially what neurodivergent people are dealing with every day. Physical environments not designed with our sensory needs in mind, social environments that require elaborate masking strategies to navigate, and settings or systems that don't provide information and activities in accessible formats. And to give you an idea of how burdensome this can be, I'm going to pull out just one of those things, social environments, and let Daffodil tell you about her experience with it. Now, Daffodil is a pseudonym and a participant from a qualitative study I ran looking at autistic adults' experiences of social communication. And every time Daffodil has a social interaction, there are some rules she has to remember. She checks her body language and her facial expressions and whether her breath smells as she monitors her eye contact because her auditory processing issues mean she lip reads to understand what's being said, but to pass as neurotypical she needs to meet people's gazes regularly. She has to keep track of how much she's been speaking and how much the other person has been speaking to make sure she's not dominating the conversation. She needs to remember to reciprocate social pleasantries. She needs to remember not to interrupt. She needs to remember not to be too loud or too quiet. She needs to remember to monitor whether other people understand what she's saying, but not to over-explain or repeat herself too much, or they'll get annoyed. And she needs to actually follow what's being said, of course. In her own words, I can be so focused on engaging correctly in the conversation that I miss the actual conversation itself. And Daffodil is by no means unique. Many of our participants shared similar experiences of missing being able to actually engage with things because they were busy trying to perform engagement correctly. Yes, I am on the correct slide. And again, this is just a description of the kinds of demands social masking makes on someone's capacity. This isn't taking into consideration differences in attention or memory, inappropriate physical or sensory environments or information formats, mental or physical health issues, bullying, and plain old day-to-day variations in stress level. The list of things that might add to somebody's jug goes on and on. And some neurodivergent people might also have reduced jug capacity if they find self-regulation difficult. Or certain things might fill up more of their jug capacity than they would a neurotypical person's. And what we risk doing with support and interventions is just filling people's jugs up further with more things to remember, more demands, more stressors. We also risk, as with Daffodil, giving people sets of rules that make them seem to be struggling less, but only because these rules are encouraging them to mask their neurodivergence. In reality, these rules could actually be reducing their capacity to do things that are enjoyable, meaningful, or useful to them, like pay attention to conversations, which is fairly basic. What neurodiversity challenges us to do then is to center the person and their experiences, their perspective, their capacity jug when we support and intervene. It says that to really tackle the problems a neurodivergent person is experiencing, we need to put ourselves in their shoes and ask what's going wrong here. Which conveniently leads into thinking about what the principles of neurodiversity affirming support are. This is, again, more of an ongoing dialogue than a question, but there's 2 important starting points to that conversation that I want to make here. The first is that if we're asking what's wrong here from the neurodivergent person's perspective, the answer is probably not going to be myself. So we should be assuming first that the person's environment is the problem, well before asking whether there's something about the person that needs to change. There's a well-established principle in the social model of disability which points out that people are often primarily disabled by their environment. Someone who uses a wheelchair, for example, is not disabled by their use of a wheelchair, but by a lack of ramps to access buildings, lifts to get between floors, and doorways wide enough to get a wheelchair through. The more difficult component of this, though, is that other people's behaviour count as environment too. Your social environment can be just as disabling as your physical one. But social environments are harder to make accessible because accessibility for social environments requires everyone in them not just being accepting of social differences, but modifying their own social behaviour. An example, I, like many autistic people, dislike eye contact. When I'm around my autistic friends, we take turns looking at each other's faces whilst the other looks away. This lets us read each other's expressions. We can do that, I promise you, without having to make eye contact. It takes pressure off me to mask, an issue I often have with neurotypical people, even when they've said they're okay with me not making eye contact. The problem is that getting neurotypical people to display the same behaviour that I automatically get from my autistic friends requires them learning and applying an arbitrary social rule for me. And this is a lot of work, but neurodivergent people are already doing this constantly all the time. From Red, another participant in my study, it feels like we spend so much time trying to derive and memorize rules for how neurotypical people want to be interacted with, from manually controlling facial expressions and eye contact constantly, to thinking about how we walk or sit or move or speak, to moderating what we talk about and for how long, and being careful not to be too weird. All the time. It's exhausting and pretty much thankless. I don't think neurotypical people really do the same for us, or even anything close. Dr. Milton's double empathy problem points out that the onus is often on the autistic, or, to apply it more broadly, neurodivergent person to change their behaviour to accommodate others. This is not only unequal in the it's not fair sense, it's also actively disabling. Neurotypical people getting used to meeting neurodivergent people halfway in terms of the burden of learning social rules is a prerequisite for producing a supportive environment. The second point I want to make is that support and interventions have to be focused on improving a person's quality of life. And this is really pretty obvious, and I feel like there are probably very few support and interventions out there that don't claim to be focused on this. But the problem is quality of life is a highly personal concept. Take my frighteningly neurotypical mother, for instance, who is aware I refer to her as this, it's fine. She struggles to imagine a good life being one without constant social interaction, large networks of friends, going out several times a week. My definition of a good life involves several evenings a week being spent on quality time with myself, with my cat in a dark room, because I'm a bad stereotype of an autistic person. So we should be careful not to fall into the trap of stereotyping autistic people, for example, assuming that we all have no interest in social life or friends whatsoever. That's not true. But, for example, we know from research that parallel play, being in the same space as someone else whilst you're both doing separate activities, is considered a really sociable activity by many autistic people. Does a good social life have to look like an autistic person learning to love parties, or could it look like someone being able to sit in a room with their friend and do something else? We also need to think critically about whether an intervention is actually improving someone's quality of life. For example, if a social skills intervention seems to be making somebody happier, is this because they now understand how their social needs differ from others and can explain those to people and negotiate social compromises to get their needs met? Or are they now masking and are stressed and miserable about it, but are so relieved that they're no longer being bullied, ignored, and excluded for being weird that they're going to continue regardless? So this leads to our third question, which is, when do we provide support and interventions at all? When is providing support and intervention neurodiversity affirming, and when is it part of a normalization agenda? Well, there are some really obvious considerations here based on what we've just established. Could this issue be fixed by changing something that's not the person? And is this going to improve the person's self-defined quality of life? If the answers are no and yes, respectively, this is probably a really good place to provide an intervention. And there's a third component to this, though, which is whether the person potentially receiving the intervention consents. Have they agreed to it? Have they asked for it? And this is where we run into some issues. In an ideal world, everybody would be able to identify what difficulties they're experiencing, understand what interventions are available, and understand the pros and cons of each to make an informed decision. In reality, though, even aside from all the logistical issues that Max kindly identified before this talk, this is not always the case. So people may not understand their own neurodivergence and might not realize that they're struggling. They might just think this is something everybody deals with. They might know they're struggling but have traits like alexithymia or interoceptive issues which make it difficult to identify what they're struggling with. They might know there's something wrong but not be able to point to it. They might be in an environment that stigmatizes neurodivergence and or have internalized stigma and want normalizing interventions even though this might be harmful to them. If there are communication issues between them and the person offering support, they may have difficulties understanding what's on offer. If they have a learning disability, they may have difficulties assessing the pros and cons of the different options. And if they have little or no communication, they may not be able to express their preferences. And there are some people, such as children or some adults with a learning disability or a mental health crisis, who, for legal reasons, will have somebody else making decisions for them. All of this means that there will often be circumstances where someone, parents, carers, teachers, doctors, will have substantial input into decisions made about a neurodivergent person's care. In the most extreme cases, they may be making those decisions without meaningful input from the neurodivergent person. People who cannot make decisions about their own care still deserve neuroaffirming support and intervention, or neuroaffirming absence of intervention. But this situation requires us to ask different questions to assess the appropriateness of an intervention. So we still need to ask if we can change the environment first. We should assume that any intervention is going to be stressful and try to minimize that stress. Prioritize leaving people as much capacity in their jugs to learn, to self-regulate, and to communicate as possible. This is especially the case for people who might not be able to notice or communicate that their capacity jug is filling up until they're at breaking point. Secondly, we should ask ourselves if this is something that's going to reduce someone's stress. Quality of life is very personal, as we've established, but stresses are slightly easier to generalize about, especially within neurotype. For example, we know that many autistic people find physical contact very stressful, and an intervention for somebody who is, say, touch-averse to help them manage their own hygiene, so long-term we can reduce touch between them and their carer, might be stressful for them whilst we're giving them the intervention, but might long-term really reduce their stress levels. Finally, is this going to improve someone's health and or safety that, again, cannot be managed in any other way? For example, an intervention designed to get someone with minimal communication to be able to communicate when and where they're in pain is clearly vitally important, even if they're going to find the process of learning and using that intervention really stressful. An intervention to get someone to stop playing with kitchen knives, say, when we could probably just store the kitchen knives more safely, less vital. So to wrap up, here's the 3 things I hope you take away from this talk, even if nothing else sticks. Be mindful of people's capacity jug. I spent a long time making those jugs, so be mindful of those as well. We all have one. The neurotypical people in the audience, you also have a capacity jug. But neurodivergent peoples are often very, very full, and often very, very full of things that won't occur to neurotypical people. Try to reduce how full neurodivergent people's capacity jugs are, if possible, or at the very least, don't add to them. This means changing the environment first, where possible, before we think about changing the people. Neurodivergent people exist in a social and physical environment that isn't designed for us or accommodating of us, and this disables us. We can all, neurotypical people and neurodivergent people, reduce this by meeting others halfway. And when there does have to be change to the person, make sure that this is centered around their wants, their needs, and their goals. These might be very different to yours, and that is okay. We are all unique, and we don't all need to be made the same. Thank you very much for listening. And that was a lot quicker than I expected.
Thank you very much, Holly. I really liked your illustration of the capacity jug. If you'd like, you can come back and we'll answer some questions. But as a researcher, and I hope this also resonates with other researchers, we often assess people's behavior and cognition if they're neurodivergent, and then just compare the scores to neurotypical people's scores or along a continuum of some kind, without necessarily recognizing the fact that neurodivergent people's capacity jugs might already be full, and so we're kind of making these assumptions in a really biased way. So I hope this definitely influences how we take things in the future, both, you know, in the clinical side of things, but also in research, because I feel like that's really important. So thank you. It's time for some questions now, and I've had a lot of questions arrive on the iPad that I'm going to read out, and then you guys can kind of take turns to answer them. Great. So the first one is for Max Davie. And the question is, have you thought about the overlap between ADHD and autism and delayed sleep phase as a barrier to sleep?
Yeah, I mean, we think about that constantly as part of the assessment. We always think about sleep as a component of the person's life. I think both autism and ADHD traits lead to difficulty with sleep in lots of different ways. So yeah, I mean, it needs to be incorporated in any neurodevelopmental assessment, is the brief answer to that.
Great, thank you. The next one's for Holly on the issue of consent. How do you manage patients having different ideas about what support their child needs, especially when the child is under 16?
Oh boy. So I am a researcher, not a clinician. So I don't work directly with parents. Most of my research involves adults. I think that's a really difficult one because neurodiversity as a whole kind of demands that we have a radical restructuring of how we understand society and the value of a human life and all sorts of stuff. So a lot of it is like, in an ideal world, parents would understand neurodiversity and would get that their kid needs different stuff. I think we need the people who are going to be on the front lines of diagnosis and support to be really neurodiversity informed, in terms of there are ways that you can explain this to people, even people who are very resistant to the idea. You can, people who might be like, oh, well, neurodiversity is a load of bunk. If you point out, my lovely jug metaphor that I made, a lot of people can kind of understand that even if they are resistant to the idea that there's nothing wrong with autism. They can understand the idea that, your kid's dealing with a lot already, and what we are doing is actually trying not to add to it because the evidence shows that this is not necessarily going to help them. So we need the evidence base there, and we need the knowledge there kind of all the way through the chain from researchers and clinicians down to kind of support workers and stuff.
Yeah, that's really interesting, thank you. And I agree that metaphors can really help ground a lot of our ideas and solidify and make them practical, so that's great. This one's for Max. This question is presumably about your work in the NHS, but also for ADHD UK. How have you been successful at changing old-fashioned, usually psychiatry-based views that only medics can assess and diagnose ADHD?
Well, I don't think I've had any role in that. I mean, I think the nice guy, old-fashioned psychiatrists, well, there are some. I think, the NICE guidance has changed, and it doesn't have to be it doesn't have to be a doctor anymore. It can be an appropriately trained person, and I think that's a key and vital change. I think it broadens out the number of people who can potentially do it. I do have a little bit of a worry that we haven't really defined what adequate training is, and I think there is a potential, as things develop, that there are people who are not necessarily that brilliantly trained who are in the private sector diagnosing people on demand, which I'm not completely sure is entirely safe, particularly given the fact that you're often giving out medication at the same time. So yes, there's the old-fashioned ivory tower thing, but then there's also the free-for-all, and I want something in between that.
Great. For Holly, what do you think about many funders prioritizing early interventions for children?
Oh, God. I could talk about my very, very complicated opinions about what early interventions are designed to target and when we should be doing them all day. I think the basic is that inherently early interventions are not evil, right? Inherently early interventions designed to try and improve somebody's communication, designed to try and improve somebody's quality of life. These are not bad things. The danger is that it's very easy, especially when we have a very deficit-based view and understanding of neurodevelopmental conditions, to produce early interventions where we're unclear whether what we're doing is improving somebody's quality of life and communication skills, or whether we're eradicating those neurodivergences. And I think really the key thing going forward is that we have neurodivergent young people, we have neurodivergent adults, we have parents, we have people who fill multiple of those roles involved in designing and assessing those interventions, so that it stops becoming we have done some research and know that autistic people do X and there is a problem with this, and becomes more focused on, okay, so we're doing this thing. How do people feel about this? How do adults feel about this? How do parents feel about this, et cetera, et cetera?
Yeah, that's great. This one is kind of for both of you, so either you can answer or you can both answer. How do you support someone with low motivation and a lack of personal goals as a feature of their neurodivergence, which is also often called inertia? And inertia can kind of arise as a trait of multiple different kind of underlying conditions, for instance, depression, but also as a feature of like neurodevelopmental conditions like autism and ADHD.
Is that a question from my wife?
I don't know, it doesn't have a name actually.
No, exactly,
So.
it could well be. Do you want to go first?
Sure, I can. That's not the way I have heard inertia used by other autistic people, but that might be because I am quite siloed into kind of social communication. I think that some of this is, again, about like reframing how we decide whether a person has value. Like, not everybody all the time has to be striving to like get better at everything and, become amazing at this and become amazing at that. So I think there's this very like, we expect everybody to be hyper competitive and really goal oriented and stuff. And actually, if your kid is 16 and is like, I want to go work picking vegetables on a vegetable farm, and these are my life goals, I'm already capable of doing this, I don't need to learn anything else, it's going to bring me great joy, that's fine. That's really, like, I don't necessarily think always we have to focus on someone improving and becoming a better version of themselves. Sometimes we can just say, well, if they're happy where they are, let them be where they are. And maybe actually if we give them space to be for a bit, that they then start looking towards the horizon, but maybe they don't, and that's fine if they're happy.
So the reason for my slightly facetious response is that that's very much something we struggle with my son. He wants to do things. You ask him what he wants to do, and he gives a list of things he wants to do, but actually getting them done is the secondary problem that we struggle with. So I don't have an answer to it, but I think what we have found helpful is to sit down when he's calm and his jug is relatively empty and say to him, well, how do we break this down? Is this actually important to you, or are you just saying that it's important because you think it's important to us? So break down what the person actually wants, and then break down getting to where they want to be into manageable pieces. That's the only kind of very brief tip I can give.
Yeah. Great. I think if I can just pop in terms of that sort of inertia, I think the task breakdown and developing strategies to manage that is absolutely key, because I also have that, and actually doing stuff like setting timers or ramping myself up and then going for something, or having a really thorough breakdown of the tasks into individual pieces. Those sorts of inertia problems are really interesting. There's Lene Buckle. Lene Buckle, I think, who's doing some really interesting work on this and might have a poster around at some point, so go look for Lene.
Yeah, great. Yeah, and I've been looking into some of these things myself, and I found an interesting one recently where someone tackles their autistic and ADHD inertia by, so for instance, if they want to do the dishes in the evening and it's piled up across the day, They play medieval lo-fi music and pretend that they're in a video game and closing up a tavern at the end of the day. So you kind of have to get creative with it.
Isn't all medieval music lo-fi?
Maybe.
I don't know. Anyway.
I've never searched for medieval lo-fi music. I'm going to have to do this.
But anyway, you might have to kind of make it more interesting for yourself, and then it's easier to get a task done. Do we have time for one more question, or are we kind of... No, that's it. Okay, well, thank you both very much
I'm not
for your
going anywhere
talks.
if anyone's got something.
Yeah,
And thank you for your questions. And you'll be able to access these questions as well in the app later on. If you just kind of, I can show you on my phone, but if you kind of click through and click the questions bit. Yeah, thank you very much.